right, let's get started. Want to welcome everyone to the New Mexico Family Advocacy Program's 8th 2020 ECHO presentation. NMFAP is a model of respondent parent representation being implemented in the 13th and 2nd Judicial District that utilizes interdisciplinary teams of lawyers, social workers, and parent mentors working effectively together to provide quality representation and the advocacy and support families need for reunification or other preferred outcomes in the child welfare system. As participants in our community of practice, you will receive professional development from the experts and early adapters of the NMFAP model, learn best practices, and collaborate to solve issues that present challenges to providing quality parent representation in the court system. So I want to welcome everybody. My name is Camille Hancock, and I am one of the lead social workers, and I will be the facilitator today. We also have Jen Vieira, who is providing technical support, and will get things in the chat going.
Hi folks, sorry my camera's not on and providing that tech support. I want to make sure I have a solid connection, so it's going to be up. But just to remind you all to press *7 if you're on the phone. *7 mutes and unmutes your phone. And for the rest of you all, just mute and unmute as you interact with the session. Thank you.
All right, so we are going to get started. Today's workshop is by Dr. George Davis, and it's on psychotropic medications in child welfare cases. Dr. Davis is a board-certified psychiatrist and has been in practice since 1990. He is currently supervising child psychiatrics at the University of New Mexico Family Medicine Clinics in Bernalillo County. Dr. Davis previously served as the Director of Psychiatric Services for Juvenile Justice Division of CYFD, and prior to that was the Medical Director for the Children's Community Mental Health Clinic at the Bernalillo County Juvenile Detention Center. Dr. Davis has served as an expert witness on a variety of topics in psychiatry, including adult and juvenile forensic psychiatry, developmental trauma and criminality, and adolescent psychiatric treatment and program design. Dr. Davis has presented in many professional settings, including at medical and psychiatric conferences, before government agencies and commissions, and for child welfare advocacy organizations, and has presented at the New Mexico Children's Law Institute on multiple occasions. So we would like to welcome Dr. Davis and let him get started. Remember to press mute, so then that way we can hear Dr. Davis. All right, Dr. Davis.
Thank you. Very nice to be here. Very nice to be here. This is the topic that I think about all the time, and so I assume that everybody thinks about it all the time. Or at least I hope so. Oftentimes, you know, like Leslie and I were saying. Well, let me make one clarification on the on the that little bio. Doing psychiatry with the family medicine at UNM is something that I was doing with the Adobe grant, which I would like to talk about in just a bit, maybe at the very end, because the Adobe grant is this multi-generational approach to dealing with children who are in the juvenile justice system. And it's a model, though, that is highly applicable to this. So I'm not really doing that very much anymore, but you know, that's where that came from. And the other thing is, a lot of times, a lot of the discussion, like Leslie and I were saying, there's more information about the use of psychotropics with children who are in custody. In fact, there's been federal intervention in that, and we are always, I've been, since 2006, frankly, I've been doing that, making efforts to put better kind of controls over the use of psychotropics with children who are in custody. But like Leslie and I were saying, it's the very same, the adults is the same population farther down the road. So let me open this screen share. like that. And the, hold on. Let me see which button. I don't know why it's not advancing it. It worked just a minute ago. Let me stop share and go to a different, we'll go to this one. And then bring it up and see if it gives us what we need. Yeah, I don't know why, the other one wouldn't move. So the parents are very much the same as the children who are in the foster care system. And usually they have that kind of history themselves, if you know what I mean. It's like, it is, we talk a lot about historical trauma, but which usually applies to populations or color, you know, like Native Americans or African Americans. Generational trauma is what applies here because it basically is passed from parent to child, and it's been passed for multiple generations. I'll just say it straight out. And there's reasons why, there's mechanisms, there's reasons why that gets transferred. I mean, obviously you think, well, of course it's historical trauma. It's been going on a long time. It's, you know, it's part of their history, but that's not exactly what the mechanism is. There's ways that trauma gets transmitted through generations. First is, of course, the things like the social determinants of health. I think everybody knows that term, I bet. But the social determinants of health are the things about your life, your lifestyle, your income, your social setting that determine basically what your health is. And that certainly applies to mental health as well. And so it's things like, you know, resources and the fact that these parents don't have those resources and oftentimes are afflicted with, you know, poverty to some degree, sometimes extreme, but it also has to do with where they're housed, their access to health care, and it gets down to things like diet, environment, and neighborhood. I'm not going to perseverate on that, but I think you all know what I'm talking about. Is where you live oftentimes determines how well you are. The other way it gets transmitted is through parenting, and you know, trauma. Parents that have been traumatized in their own life tend oftentimes to parent in that same way, or it's really the other way to say it is that's not as common, that those who are parenting inadequately or in some sense ineffectively, those parents have usually been parented that way themselves. And then there's biological mechanisms of transmission. And I want to emphasize that trauma gets passed along not just by repeating the trauma, but things like epigenetics pass it on from one generation to another. And epigenetics is complicated, but it means that the sort of things that happen to us, whether those are abuse and neglect, or substance abuse, those are coded into parts of our genetic genome. And it obviously doesn't change the genes, but it changes the expression of those genes. And so trauma gets handed down biologically as well. And you will find that that's true, that children who have not directly experienced they have not directly experienced trauma, are nevertheless affected by the trauma that their parents experienced. Adverse childhood experiences. I know everybody on here, you don't need to raise your hands or say amen or anything like that. But I know everyone on here has thought a lot about the adverse childhood experience study. And I just want to make a couple of comments on that. Partly because, without a doubt, it is the most important public health study that I think has ever been done. It is the most important in terms of organizing our healthcare system. And I remember, you know, the people that wrote this back in 98 is when they published that. Robert Anda was one of those, and I remember hearing him one time, and he said when they realized that the things that happened in childhood were manifested throughout the life of the individuals, he realized that this changes everything. And it does change everything, only we don't really know what to do about it because it keeps happening, if you know what I mean. And so it's easy, those 10, the comment I want to make about those is those are the 10 adverse experiences. It's not by accident that they added those on there. You know, there's not all of those adverse experiences, 10 adverse experiences have in some sense to do with the integrity or the security of the parenting and the caretaker setting. And that's how trauma gets passed on. It is through instability of the caretaker setting. So that's why you don't, on adverse child experiences, you don't have things like hurricanes, car accidents, and poverty is not an adverse experience. It is an adverse experience in the common sense of the term, but poverty per se is not how the ACE transmission works. And the reason it works through the parenting situation is because it's the thing that develops a child's early regulatory capacity. And I'm talking about in the first 5 years, actually most of all in the first year. The thing that gets a child and grows the brain in ways that will allow them to later regulate is through the primary caretaker. The soothing, the stability, the caretaking. And if you've got, you know, I don't right now have any babies in my household, but I remember well that all you ever do with a baby is transmit. All you ever do with a baby is take care of their needs. They cry, you hold them, they're hungry, you feed them, they're wet, you change them. It's that caretaking, and that's what's growing those early regulatory capacities, which are largely early developmental events. When you miss them, you're altered a little bit forever. It's a hard thing to hear, except that some of the changes that happen early on are forever. Doesn't mean they can't be addressed, but it means that they change things. The dose-dependent damage of adverse experiences, you all know this, but the more adverse experiences you have, the more likely you are to have everything from heart disease to depression, to alcoholism, to IV drug use. Some of those effects are profoundly robust. For example, IV drug use. When a person has 6 or more of those adverse experiences, the chances that suffer from IV drug use are 46 times what they are. That's 4,600% higher. And if you talk to individuals who have problems with addiction, with IV addiction, oftentimes, almost always, frankly, they've had early childhood trauma. Suicide attempts, if you have 4 or more of those ACEs, your chances of making suicide attempts is 12 times as high. So that's all I want to say about the adverse experiences, but it underlies pretty much everything we're doing these days. It is the basis of modern medicine, I think, or should be, to the extent that we can make it. Diagnosis. One of the biggest problems in treating the adults and the children in the child protective system who have been traumatized is that it's very difficult to pin a diagnosis on it. The problem is trauma, and we pin a lot of different diagnoses on it, but really the underlying problem is trauma itself. And therefore, there's a wide range of symptoms that will present with trauma, but the underlying issue is trauma. One word about the diagnosis of PTSD. Not all of the individuals, either the children or the adults in the child protective system, not all of them have PTSD. PTSD is an actual syndrome where a person has flashbacks and they spend a lot of time avoiding certain stimuli so they don't remember. And it's, there clearly are treatments, which I'll talk about in just a minute. But oftentimes what our patients, whether they're children or adults, are suffering from is developmental trauma. And developmental trauma is when adverse experiences or when trauma itself of any sort happens during that developmental period. And the reason it's different from PTSD is it's fundamental. It's in the regulatory capacities. And the regulatory capacities are hardware. It's not that people who have early trauma only have bad memories. It's that their regulatory capacities, which I'll talk about in just a minute. The symptoms of that dysregulation are going to be inability to regulate mood, inability to manage anxiety, mood instability, like going from anger to tears, sadness to unrealistic kind of happiness. It's mood instability that is not bipolar disorder, it's trauma. A lot of the inattention that we're calling ADHD is failure to be able to regulate attentional kinds of capacities, which are in a specific place in the brain. And then they'll also have social and interpersonal problems that lead them into contact with the criminal justice system. Van der Kolk himself, I don't know how much people have read, but Van der Kolk's kind of the grandfather of trauma studies. And his point is that the criminal justice system is filled with people who have been traumatized. So one of the most problematic regulatory capacities that gets damaged from people who have had early childhood trauma or trauma along the way, because the same thing is true of PTSD, as we note with people who are coming back from the Iraq War, is that they have what we call hyperarousal. And hyperarousal means, chemically, it means that they are more flooded with activating neurotransmitters, and they have less capacity for dampening those down. And so an individual will actually run higher levels of things like epinephrine, norepinephrine, all the activating neurotransmitters are measurably higher. Also, they'll have physiological signs of trauma, meaning they might have a slightly higher heart rate, or they might have a more reactive heart rate. When small things happen, their heart rate shoots up. And they might have a higher blood pressure as well. So hyperarousal is a physical event that manifests behaviorally. And it manifests in explosive behavior, impulsivity, reactivity, like small things. Individuals tend to overreact. They have more anxiety in the sense that they're more easily frightened. They have a higher startle response. They have greater expressions of anger. All of that is part of the hyperarousal syndrome that results from trauma. There's also a fair amount of motor restlessness. As you notice, we always want, not we, but they, whoever those guys are that we're talking about, trauma always wants to be called something else. I've had residents, psychiatry residents, who said, how can you possibly treat something that always looks like something else? And of course, it does look like something else. It always manifests like a mood disorder, reactivity, agitation, irritability, anger, criminality. It always looks like something else. That's the way. And so people want to call it ADHD. Because if the prescriber can name it, then they can pin a medicine on it. And so the attention problems of individuals with trauma usually is not standard ADHD, and it usually doesn't respond well. Sometimes it does, but it usually doesn't respond well to stimulants like Adderall, Ritalin, or any of the other stimulants like Vyvanse or Metadate or any of the other stimulants that we might use. It's not bipolar affective disorder, even though their moods go up and go down. That's not what it is. It's not antisocial personality or conduct disorder, even though we have to call it that because their behavior manifests sometimes in explosive and even, aggressive kinds of ways. And it's not technically an anxiety disorder, although in some ways it's all those. The question is, if this is what happens, my own phone rings while I'll turn it off in just a minute. No, okay. Hold on, let me go turn my phone on.
While he's doing that, I had put in the chat, if you could sign in the chat box by putting your name and your email address.
If there's things you want to draw my attention to, Camille, that if there's things in the chat box that I should be answering, let me know. Otherwise, it's hard for me to attend to the chat and the slides at the same time. So just flag.
Okay, I'll keep an eye on it for you.
Okay. Okay, misdiagnosis. So consequently, if you look at people who will come in who have a history of trauma, they might have seen a provider that has them on a stimulant for hyperactivity, a stimulant meaning, Adderall, Ritalin, or some version of those. They might be on an antipsychotic for odd thinking, beliefs, auditory hallucinations, which are not really psychotic in themselves, agitation, explosiveness. They might be on an antidepressant for irritability or depression. They might be on a mood stabilizer, and they might be on a hypnotic for insomnia. Hypnotic is named for just sleep aid. Now that's not necessarily bad, but you can see that person came in with 5 medicines. It's not common, it's not uncommon at all, especially with kids that are in the juvenile justice system, or for adults who have a laundry list of psychiatric presentations. So it's not uncommon at all to be on 5 medicines. I'm not saying that's bad, but it's almost never effective. It's just piling up medicines in the hope that that you're going to get lucky, and it doesn't really attend to the underlying trauma. All of us get into this box, so all of us, meaning all prescribers, do. I used to review different medical regimens. Occasionally, I'd run across one that was particularly egregious, and I would find out that it was my own. So it's easy to get boxed in by this when you're trying to prevent a disaster. You know what I mean? You don't want the parent to lose custody. You don't want the child to go into the juvenile justice system. And so you end up piling medicines, but it's hardly ever effective. The real principles are treat the symptoms, not the diagnosis. It's unnecessary to call mood instability bipolar disorder. It's just not necessary to do that in order to treat it. And moreover, that's not what it is. There was a point in time where bipolar disorder, during a certain period of time when Big Pharma was pushing medicines and ways to address it, and when the insurance companies were demanding a diagnosis, the diagnosis of bipolar disorder during a certain 10-year period, I think it was 94 to 2004, went up 40-fold, 40 times. Now that's impossible. That's logically impossible because bipolar disorder is a genetically carried disorder. It has the same frequency as schizophrenia. And schizophrenia did not go up 40-fold because it's not a popular diagnosis. And so you treat the symptoms. As Murphy's Law, one of Murphy's laws is that just because your doctor has a name for what you have doesn't mean he knows what it is. And I think that's an important thing to recognize, is that giving it a name doesn't really help matters. I'm not saying don't, but I'm just saying don't be too eager to push it into another diagnosis. Call it what it is. The other principle is use medication for support of function. You don't try to fix everything, but you want that parent to be functional. You want them to be able to parent. You want them to be able to hold a job. You want them to be able to conduct, to negotiate the maze of CYFD and all the requirements that might come from the court. And so you use medication to support function very selectively and intentionally. Using medication to support and assist therapy, because frankly, the real treatment for trauma are therapeutic interventions, not medical interventions. Prescribing is an assist to therapy. It's a way of helping a person to manage either emotional or reactive kinds of responses so that they can tolerate the rigors of therapy. Treat conservatively is another principle, meaning it shouldn't be the case that when a person, you see them for the first time, they walk out on two different medicines, one of them an antipsychotic and one of them an antidepressant, or one of them a mood stabilizer. Treat conservatively is what we teach the residents constantly. Treat one at a time, treat conservatively, start slow in case of side effects, look for benefit, have a target symptom. All of those are prescribing principles that we try to instill in the providers who are learning to provide care for this population. Avoid opiates and benzodiazepines. I think you guys know why. It's just a slippery slope. And it's a game that you hardly ever win. You might think that if you just used a benzodiazepine for anxiety, it might stabilize it and everything might get better, and you might win it. But usually it's a slippery slope. That's all I can say. Treat the substance abuse medically, meaning if an individual has an opiate addiction, that should be treated most successfully, frankly, with things like Suboxone or long-acting opiate blockers like not Pristiq, but Vivitrol. Vivitrol is a long-acting naltrexone. But the way you treat substance abuse is with Suboxone, for example. It's a way of lowering the craving while preventing overdoses. It's a very ingenious medication. It works, it's been proven to work. And I highly recommend that the substance abuse be treated in these in individuals. It's not a peripheral event. It can sometimes be the main show, the main reason why people are losing their kids. But then, of course, no rule applies every single time. That's all I can say. And so you have to address each situation, each person individually, like with the benzodiazepines. I mean, I've got patients that say have panic attacks, and panic attacks are noxious physical events with, pounding, racing heart rates, sweating, dizziness, shortness of breath. And so sometimes you do treat those with the benzodiazepine, and sometimes it works fine. I've got patients where, they have 15 tablets of benzos for the month, something like Valium or Ativan or Alprazolam, which is Xanax. They might have 15 for the month, and then they have to decide how they want to manage those panic attacks. It's not enough that they can take one every day. It's not enough that they can cause a real serious dependency, but it does help them out. So every single rule, the more individualized you make your treatment, the better off you are, and the more help you're going to do, basically, because every, parents, like everybody else, are snowflakes. You know what I mean? There is not a single answer to every single problem.
So, Dr. Davis, we had a question in the chat. It says, does that go for any MAT, including methadone?
Yeah, it does. Thank you for asking that. It does. The reason for why Suboxone is an easier choice for methadone is one, it can't be abused. Suboxone has, I'm just going to say what that is. It's got buprenorphine in it, and it's got naltrexone in it. Buprenorphine is an opiate, so it reduces the craving, but naltrexone is the same thing as Narcan. It's a thing that prevents overdose, and it's in a very carefully titrated balance. And so you've got protection against overdose, and you nevertheless have with the cravings. Methadone, unfortunately, is abusable. That doesn't mean it is abused by people, and I think it's a very good thing to do in certain kinds of situations. Sometimes in pregnancy, it is more convenient to be doing that. There are certain situations in which methadone is an improvement over methadone. Methadone is an improvement over Suboxone. But yes, I endorse all the medical treatments of the treatment of substance use and addictions. I'm going to move on, but feel free to come back to that if we want to. I just wanted to address some treatment principles about depression. I think, it's not uncommon that I will see individuals who have been treated for a long time, because as we all know, sometimes people change providers and they will come into a clinic and they might have every single medicine on board except for something for depression. There might be a mood stabilizer, there might be an antipsychotic, which I'll talk about why those would be used. There might be both of those. There might be any combination of these. There's oftentimes a stimulant there for ADHD, but the thing that's not there, and the thing that hasn't been tried, is treating the depression. It's very underrated. I almost treat depression. And partly because depression isn't always what it looks like. As we all know, it can present as irritability, intolerance, moodiness per se, which is not really bipolar disorder, but just that reactivity is also part of a depressive symptom. Mood itself is the most fundamental functional category. I'm not saying that every time it's going to work to treat it, but I think it should always be attempted in individuals who are in the system who have a pronounced and probably long and severe trauma history. Mood is always going to be part of that mixture. So it's, when I say before, treat to improve function, treating the mood is one of the most important underlying functional categories. As we all know, you can have the very same thing happen on 2 different days. On one day, you come home and you say, I hate my job. I'm going to quit, or I can't stand to be in this relationship with this person anymore. And then the next day, the very same thing might happen. And none of those things you feel. And it's all because of underlying mood. Mood is the filter through which we interpret things. And it makes the intolerable tolerable. Or it makes, the perfectly average event seem intolerable. And so it will control things like the amount of energy a person has, how much optimism they've got, things that really determine your future in some ways. They determine how much tolerance you got for interpersonal activity, interpersonal interactions. And also it determines things like patience in parenting. And so once again, I don't want to harp on this, but I think treating the mood is foundational to actually treating patients, the parents who are in the system. The reason why it's not very glamorous or sexy is because when you give an antidepressant, the response is usually quite slow. The response is usually pretty subtle, meaning it's, you get a marginal benefit. Sometimes on your very luckiest day, you give an antidepressant to a patient and they come back the next time and say, I feel better. My whole life has changed. I can't believe I didn't do this before. But it's a rarity. I mean, those are the sort of sort of days you pray for, because you need one of those every once in a while to keep up your efforts. So it's usually very slow and it's a very subtle response. And the second thing is, it's unlikely that you get your best response from the first antidepressant that you try. Usually it involves multiple trials. And usually you give, I'll just tell you the details. You give one medicine and you give one medicine. I'll come back. I see, be sure, I see that Nita Day came up here too. Let me finish this and then I'll come back to it, okay? The details of treating for depression are, the first thing you try doesn't work. Sometimes you try as many as 6 different antidepressants. They might all be SSRIs, but nevertheless, one tends to work and one doesn't. It's very hands-on. And so it's great if you go to a family medicine doc and he starts Prozac or she starts Prozac and you feel much better. That's fine. But if you're going to have 6 different trials, very few family medicine docs are going to have patients or know the whole library of different medicines behind that. So you realize that's hard for the provider. Who cares about the provider? It's hard for the patient to lower their expectations and expect marginal benefit over a long period of time. Nevertheless, that benefit's real. I've had people come in, like a guy my age would come in and say, I'm not going to take that antidepressant anymore. It didn't make any difference at all. And his spouse would look him in the eye and said, the hell you want? You are going to take that. Because it makes a big difference that you don't necessarily note. We are not always the best judge of our own moods, frankly. Camille, do you want me to interrupt me and give that question?
Yes. So how long should methadone be used? I have several parents that have been using methadone for years with no plan to come off of it.
It can be indefinite. It actually can be indefinite. And if a person is stable and doing well, and once again, if it's functional, if they are able to function as a parent, are able to hold a job, then usually it's better not to interrupt it. It's the same issue for Suboxone. As long as it helps. And sometimes you try to change or you try to get off it and it doesn't work as well and you upset the apple cart. So really it's indefinite, frankly. It isn't really seen like that. Insurance hates that answer. But what does insurance like, frankly?
All right. And then Nita, do you want to ask your question?
So I just had a question. When you say you're treating mood in you're trying different prescriptions, over time, does it come to because I've had people who are like, well, yeah, I've been diagnosed and I've always taken these antidepressants or drugs or something, but it's like, well, it may not be working. Like, do they stop working and I think in particular for women, this is an issue that as we age, our chemistry in our bodies change.
Yeah.
So am I imagining that over time they might need to go get a new, I don't know, try a new round or something if they think that something's not working or? No,
it's not your imagination. I wish it was. But I'll tell you what happens over time. It becomes the new normal. Like that guy who came in the office and said, this stuff isn't even helping me anymore. I'm not going to take it. It becomes your new normal. And the new normal, it's very hard to know whether the antidepressant is still effective or not without going off it for a while. So it's a little like going to the optometrist, you know, it's like better or worse, better or worse. And so a lot of times if you can't tell, you try another medication. There's a little bit of danger in that. There's some literature that says that that multiple trials of medicines reduce the likelihood that one is going to get traction. Nobody knows why that is, and it's mean it should prohibit you from finding out the answer to your question, because you're right, sometimes they don't need it anymore. There's not, one of the beauties about treating with antidepressants is that they don't have as many serious side effects. You know, they don't cause, usually, they can do anything, but they don't usually cause a lot of weight gain. They don't have metabolic kinds of compromises. They don't have the movement disorder problems that antipsychotics have. And so usually you can stay on it, you know, indefinitely. But sometimes you have to find out. And people are going to want to find out. And so I try to, if people think it's not helping, I usually, it's possible they're very right. And I usually try something else. So it's not your imagination. And it, like I said, you know, it's habituation. Whatever you're used to seems like it's the average. Sometimes you find out when you quit that that it has been helpful, or it was helpful, and you go right back on it. But the only way to find out is to make a trial.
So, Dr. Davis, we have another question.
Yeah.
What about getting off psych meds with medical cannabis?
Say that again. What's the question?
What about getting off psych meds with medical cannabis?
Well, I'm not opposed to that. I mean, I think that happens sometimes. Cannabis is the universal tool. You know what I mean? A lot of times individuals that I'm seeing, even if they're adolescents, have been using cannabis since they were, I hate to say it, 6, 7, 10 years old. And it is what they use to, one, they will say to me that I cannot sit still in school unless I take this, or I can't keep a job unless I take this, or I can't sleep at night unless I take this. And so it is in the world where I always try to not just respect, but follow the wishes of the patient. It is oftentimes what they want to do. It's not always the best thing, but it does regulate. What it's really doing, when I talk about regulatory capacities, you know, the fact of being reactive, anxious, irritable, motor restlessness, cannabis does reduce those, but it reduces them with a mild kind of fog. And that fog is particularly problematic for some people. For some, it's the only way they manage, though. And I never try to stand in the way of a person who wants to try cannabis, and even if they're using them with psychotropics. So I know that's a generic answer, but it's true. You know, the patient does know best ultimately.
Okay, and we have another question. Do people ever come off of the antidepressants? Is it that you want people to take the antidepressants for indefinitely, or do you treat that period of depression for some period of time, and then if the patient can successfully maintain off the drug, then keep them off of it?
Both and. It's very common that you will treat, see what I mean? Always yes to every single, it's the secret of psychiatry. The ambiguity is so profound that it drives some people crazy. But the answer is, if there's a person who has a particular life stressor, it's very common that you will treat depression for a while. they're going through a divorce. Maybe they've lost their children, the custody of their children. They're trying to get it back. They're having interpersonal problems with somebody, or they're just deeply discouraged. And so you do treat that for a bit. The times when you use it, there are many different kinds of depression. There's situational, technically there are, but they look the same. But technically, there certainly are situational depressions caused by environmental situations. And when those environmental situations go away, people don't need them anymore, and they shouldn't. But then familial depression, sometimes they run in families, and there are substantial numbers of people that stay on them for life, basically. I usually tell people, you can stay on this till you're 95, and then you're going to have to taper off, to get ready for your end of life activities or whatever, you know what I mean? But you can stay on them forever. You can treat them episodically. Everything is yes to that. Should I go ahead?
Yes, go for it.
Okay. The other treatment principle with regard to psychosis and mania, I only specified depression to advocate for the treatment of that. Psychosis and mania, I put those together because there's real mania, and then there's popular mania. And popular mania is, man, I was so manic. Or my mom, I hear it all the time. My mom's manic depressive. And so, it's not mania. That's my point. That's not real mania. Mania is a technical term that is really a kind of loss of reality testing. And that loss of reality testing is a very serious thing. It involves grandiosity, paranoia, and usually a bad outcome. I don't mean they die, but bad things happen. People go to Las Vegas with a new gambling technique and spend the family fortune and get married while they're there. Or, you know what I mean? That's mania. That's what I'm talking about. And that's what medical mania is. Part of the reason that bipolar disorder is overdiagnosed is because people aren't aware of what mania means. Mania oftentimes involves delusions as well. And those delusions oftentimes involve, 3-letter acronyms like the FBI is watching me, the IRS is checking my taxes, the KGB is online, or GOD. It oftentimes they're grandiose. They involve God Himself, and so that's what I'm talking about with mania. It's not good to lower the standards on that because it leads to a lot of misdiagnosis. Psychosis is the same way. A lot of patients who have a lot of trauma, they will say things like, "I hear someone calling my name at night," or they will say, "I see shadows, and I don't know what they are. It's usually out of the corner of their eye." That's not a real psychosis, and it's not a good idea to amp it up and treat it with an antipsychotic. Psychosis is loss of reality testing. And if it has a medical diagnosis attached to it, like schizophrenia, or, like I said, bipolar disorder, the mania that involves in bipolar disorder can also be a form of psychosis. Then it becomes dangerous and needs to be treated. And also, I won't, it's too long of a discussion to get into dissociation, but part of the spectrum of a traumatic reaction, we always talk about hyperarousal and how that makes people irritable and angry and aggressive. But when we talk about the effects of trauma, we always think about fight or flight, but we leave off that there's fight, flight, and freeze. And freeze is dissociation. It's a way of numbing, and it goes in the trauma spectrum, and sometimes it looks like psychosis. It's a loss of awareness about the environment. It's a very complicated topic, but it's not a debated topic. but it's debated as to how it manifests. But it oftentimes looks like psychosis because it involves a loss of awareness. And the treatment of psychosis for real psychosis should be with an antipsychotic, unless it's mania, in which it should be lithium instead. But I won't get into all the things that should be treated. I'm just saying over-treating psychosis is probably a bad idea. There are many real therapeutic strategies for PTSD. Medicine is not the answer, really. Medicine is an assist, but it's not the lead into trauma treatment. There's two parts to every trauma treatment. Very few people will tell you this, but almost every successful treatment for trauma has two components. One is learning to manage those post-traumatic reactions. And that usually involves some kind of self-control and usually involves some sort of like physical, somatic kind of interaction. It's through breathing, meditation. Sometimes people can re-regulate in the presence of someone they trust and love. Sometimes they use imagery. Sometimes movements like yoga or Tai Chi. And then finally, you can use medication for part of that armamentarium of how to manage the post-traumatic reactions. That's the first part, teaching a patient how to manage reactions. And then the second part of trauma treatment is a graduated exposure to the trauma memories themselves. And I always say, like, trauma in some sense, PTSD in particular, is it's a very physiological, a very physical kind of disorder. It's also a memory problem. And those memories don't get consolidated. So instead of coming back like a narrative memory, if you ask me what I did yesterday, I'd say, well, let me think. Got out of bed and I did the same things I usually do. That's a narrative memory. But a post-traumatic memory comes back vividly as though you're re-experiencing it. And the only way that usually goes away, and I know there's people on here that probably know more and do more actual trauma treatment than I do, so maybe they'll correct me in a minute here, but really the only way that gets out of that kind of memory and from column A into column B to make it a narrative memory is by repeated exposure, by enduring the memories of it, whether you put those into a narrative or you retell it or you write it down. Some ways that traumatic exposure has to be re-experienced. Exposure is part of the second half of treatment. And there's lots of ways to do that. I just listed them just for the heck of it. I mean, and this list could go on for 20 slides here because there's all sorts of versions of this. And my point is they're all doing some version of the same thing. Like EMDR is a way of reprocessing those memories while enduring them. Same with CPT. People use, say, something like DBT, dialectical behavioral therapy, is a management technique for self-calming, regulating, containing. So I'm not going to go into those because it's not, even though I know about them, I don't do them enough. But I do know what trauma treatment consists of.
Dr. Davis, I'm going to pause you real quick. It is 12:56. So for those of you that have to leave at 1 o'clock, don't forget to fill out your survey. And we have 2 more questions, I think. So one is writing on behalf of a judge who couldn't make it, but wanted to ask what resources are available to judges who suspect that a child in protective care is being over-medicated.
This is the very thing we are working on right now. The very thing. I'm working with CYFD on this, and it is one of their plans is to better contain that. And the containment is going to be when a judge or a GAL or the biological parent sees or believes that a child is over medicated or wrongly medicated, we're trying to work out a review process and to get a second opinion. That will be available soon. You know, otherwise, the answer right now is there's very little recourse to that. Even if you think a judge could order it to rain and it would happen. But as we all know, judges especially know they can't usually get a good second opinion. So really what it boils down to is a review of the case.
Perfect.
And go ahead.
And then can you talk about, we have some more questions coming in too. Can you talk about the differences between bipolar 1, bipolar 2, and I'm going to butcher this word, cyclorhythmia?
Yeah.
Or more specifically, mania versus hypomania?
Yeah, right. Yes, it is. When you look, if you were to get into a DSM-5 or 4, which is similar at this point, and look up the criteria, you would realize there's different kinds of bipolarity. There's bipolar 1, which is the same thing as old-style manic depressive illness, and that's what I was describing. There are other versions of that where the mania is not a full-blown. It's what we call hypomania, and it's increased productivity. It's what we all hope for from a cup of coffee. You know what I mean? Like good energy, productive energy. It doesn't always go that way. Sometimes it precedes an actual manic break. But there are other versions of that which do fall under that category and do respond to mood stabilizers. So it's not as clear as I made it sound. However, bipolar 2, for example, which is the presence of hypomania, which is that lower standard for mania, still goes along with a major depressive episode. So there's still that polarity. It's not the same thing as irritability. It's not the same thing as mood swings. Because mood swings are not bipolar disorder, and they're not hypomania and depression. But the third category, the cyclothymia, is a lower standard still. It is part of the same spectrum, and cyclothymia means that you transition between what we used to call dysthymia and now call persistent depressive disorder, between that and hypomania. And so there are lower standards. Usually that responds as well to mood stabilizer. And it's very difficult to tell the difference among those things. Sometimes the difference is when you realize there's a huge trauma history, and sometimes you make a medical trial of it. But there are lower standards for it. Not every mania is psychotic. Do you want to ask another one, or should I just, I can dispense with this slide and tell you for those that are going to have to leave.
So I was asking a question, but I was on mute.
Oh, sure.
Sorry. Any suggestions on how to get clients who are unable or refuse to recognize mental health problems to start recognizing? If they will only acknowledge anxiety despite exhibiting strong indicators of deeper issues, is it acceptable to encourage them seeking treatment for the ID'd issue and hoping medical mental health can help the client gain understanding?
Yeah, I know what you mean. I know what you mean. That's particularly a problem. Well, that's a problem with every person, including those of us on here. We're not the best judge of our own moods and our own mental status. Those around us that work with us and live with us are much better at interpreting our moods than we are. And I guess they're much better at admitting our moods than we are. And so usually, I mean, you all, probably a lot of people on here know a lot about motivational interviewing. And motivational interviewing is, using things like saying, I know you don't think you have a mood disorder, but a lot of other people do. And even if you don't, you haven't been able to keep a job for 6 months. You haven't had the energy to engage CYFD and to get your kids back. And usually it's that. You know, you have to find an area of agreement. And sometimes it starts with a medication trial. It's like, let's find out. Let's find out. We know you want your kids back. We know you want to do these things. Let's do an experiment. And as long as I think, oftentimes the patients think that once they've crossed that threshold, they'll be either addicted or obligated or stuff that isn't true. Like if antidepressants were addictive, we'd all be on them probably. But they're just, you know, very few of these medicines, other than the benzodiazepines and the opiates, are actually addictive. So all I can say is, a lot of times education works, and sort of like a very strong alliance with somebody. And the stronger that alliance is, the more truth you can tell, and the more they're going to trust you. You know, beyond that, it's touch and go. And I'm sure the person who asked that, you know, probably could have answered that better than me, possibly.
Thank you. That's it for the questions. If you want to keep going, we got about 10 more minutes.
Okay. Well, 10 more minutes only. I'm going to leave it open for even more questions at the end here. The only thing what you're going to see behind this, when you get this full slide set, bunch of medication categories, like all the antidepressants, not all, but most of the antidepressants, what they are, whether they're SSRIs. You're going to find a list of the antipsychotics, a list of the anxiolytics, anti-anxiety medicines, things for sleep. I just stuck those on there, not so I could talk about them, just so I could put them on the slide set and you can have a little set. Sometimes it's useful when you find out, when you want to know what this particular parent or child is on, you could look it up in the categories. And so I just put those on there. This is technically the last slide that I'm actually going to talk about. And the qualifications of those medicines are, medication isn't always used how it's named first. So it might be called an antidepressant. That is, they could be used for a lot of different things. For example, first-line treatment for anxiety is SSRI antidepressants. It's not the medications that are promoted for anxiety. It's antidepressants. That's usually, and that's partly because anxiety and depression are two sides of the same coin oftentimes. And so medication, that's true for all of them. Antipsychotics are used for mood stabilizers, and anticonvulsants. Seizure medicines are used for mood stabilization. So medication is used across categories. Many non-psychiatric medications are used in psychiatry, especially psychiatrists like to borrow from neurology. Seizure medicines are very commonly used. They don't all work, but that does not stop people from using them. But sometimes they do work. Things like Depakote has been tested and works, like Lamictal has been tested and works. And so I've followed cases where the person had a seizure disorder and mood instability, and the neurologist and I would ask each other, did you start that Lamictal? Or did I? We don't even know who started it. So, and that's, I know you think, oh my God, that's not good. But the reason why is because a lot of those medicines cross disciplines as well as categories. And off-label use is very common because we're treating something, especially in trauma, that is very amorphous and undependable. And there's the list of things like that. SSRIs, tricyclics, they're all antidepressants. So you guys don't have access to this. And so I will thumb through them, and then if any questions come up, just let me know. There's lots of different categories for antidepressants. And so a lot of times you might start with an SSRI, you think that didn't work, so you move over to that SNRI, the mirtazapine, the Remeron, venlafaxine. So you fish around basically. I hate to admit it, but it's a lot of trial and error. And there is other medical treatments for depression too. ECT, which always has a bad name, but almost always works, which is electroconvulsive therapy. It's just highly inconvenient and it has some side effects, but it does work in an emergency. And there's the anticonvulsants, which are the same thing as anti-seizure medicines. Of those, there's never been a mood stabilizer that has performed as well as lithium for as long as I've been in practice. It is the gold standard for treatment of bipolar disorder. It's not real convenient because you have to run certain blood levels of it, but it is the gold standard. And then antipsychotics, the atypicals are the new ones. You're going to see a lot of those, things like Seroquel, Abilify, Risperdal. You're going to see a lot of those used. You'll see a lot of them misused, frankly, too, because they tend to be calming. And even when there's not psychosis or genuine bipolar disorder present, people tend to use them. I'm not saying that's always bad. There's nothing bad that I talk about that I haven't done in a pinch. Because remember, you're aiming at function. And then stimulants are things like Adderall and Ritalin, which are really, there's only two real stimulants, dextroamphetamine and methylphenidate. Everything else is a version of that. Long-acting, delayed response, you know what I mean? And then things for, can I proceed, or are there questions that I should address, Camille?
Nope, you're good. Keep going.
Okay, good. Well, what I was going to say is, when I'm talking about adrenergic blockade, I know it's a very ambiguous term. It's a medical term. It basically means you're blocking down some of the adrenaline. The medicines that oftentimes work best for that are things that are used for blood pressure, because that's what they do with blood pressure medicines. It's somehow reducing the load, not always, but usually reducing the load of those stimulating neurotransmitters. And so things like guanfacine, you will see used a lot, whether it's called 10X or Intunib or guanfacine. Clonidine, you'll see used. Clonidine's mildly sedating because whenever you lower activating neurotransmitters, it's a little bit sedating. All of those are very useful in treating trauma because they don't, they do have side effects, but nothing long lasting. A medicine that affects blood pressure might make a person dizzy or sleepy briefly, but they're very useful for treating that sort of what we call hyperarousal. And then benzos, avoid them if you can. A lot of the sleep medicines are very similar to sleep and anxiety are the two of the hardest things to address because the things that address them best are oftentimes habit forming. And so they need to be used judiciously. Not everything that's a sleep aid there is habit forming, by the way. And also not all of them work, just between you and me.
Okay, we got 2 questions.
Okay.
Why are adrenic drugs used for ADHD?
Adrenergic drugs? I'll tell you why. There was a lot of research done by a guy named Gibbons, I think, but that basically thought of ADHD as, especially the motor part, the motor hyperactivity and the physical impulsivity, looked at as just an overload of neurotransmitter, of activating neurotransmitters like epinephrine, norepinephrine, which are basically forms of adrenaline. These blocked that down, and they found out that they were especially useful in treating some of the physical aspects, that sort of physical impulsivity and the restlessness. That's why they use it. They're not great for attention, but they are good for that motor hyperactivity.
Perfect. And then what do you recommend for a child that will not sleep at night? He does have significant trauma. I don't want him medicated if it isn't needed, but the foster mom needs help because she is literally up all night with him.
Yes, there you have it. There's the issue right there that comes up over and over and over again. That a kid whose main problem is sleep could blow out of a placement for the lack of a good night's sleep. I think there are many end runs on that kind of problem. Sometimes the lack of sleep, it depends on what the sleep looks like. Is it trouble going to sleep, staying asleep, waking up early? There's many different kinds of sleep problems. A lot of times an antidepressant will address the anxiety, which is causing the inability to get to sleep. It's a difficult problem to solve, so you can use an antidepressant, and I'll tell you some non-medical ways. You can use an antidepressant for the anxiety. You can use something like one of these guanfacine, clonidine, or prazosin tend to reduce reactivity and help a kid get to sleep. And usually, once a kid gets to sleep, they stay asleep. Waking up repeatedly is a different kind of problem, but those two strategies. And then the other one is sleep hygiene, which every doc is going to tell you, and nobody wants to do it. It's things like, you got to watch what you eat and drink for the second half of the day. No coffee, no caffeinated drinks. You have to have a sleep routine. You have to have the same bedtime every single night. Sometimes that works. Usually we don't want to do it.
And Karen responded, he fights his sleep until he ends up passing out, and then he's up in once an hour.
Oh, yeah. And which is very typical for trauma. It's one of the biggest, and the thing I would avoid doing is using an antipsychotic for that. Using an antipsychotic for sleep, something like Seroquel or Abilify or Zyprexa. And usually that's not a good idea, but everything else is fair game for that. And I would treat that medically, frankly. I really would. Because you realize if you're treating toward function, the only way to maintain that kid's function, like getting to school, staying in his placement, is to help him get to sleep. And I would make a try at it, even if it's something simple, like trazodone or hydroxyzine, something to lower that state of alertness and hyperarousal, which evidently lasts all night long.
And she said that they had tried trazodone, which had no effect on him. And mind you, he's only 4.
Oh, he's 4. That's good. Well, in the world of red flags, one of our reasons for a second level review is psychiatrists for kids under 4. I realize that's true. Some of the more difficult ones are ones who are infants, who've been highly traumatized and will not sleep through the night. Like I'm talking about 18-month-olds and that stuff. But for a 4-year-old, these medicines that you see up there on the screen are usually the best initial trial. They don't have long-term side effects. They don't have much side effects at all when used appropriately and well. And they can reduce what you're seeing in that wake up, the inability to go to sleep and the repeated wake up is basically activating neurotransmitters secondary to trauma. And it's a very common, I would fish around and try to treat it medically. Trazodone was a good try, but it just didn't work.
All right, and we are running out of time. It's 1:16.
Okay.
So I don't know if anyone has any additional questions. Is there anything else that you want to kind of wrap it up with, Dr. Davis?
No, just it's a pleasure to talk with people that are doing this kind of work. And I'm very happy to be here doing this. I wish you all luck.
All right. So everyone, don't forget to do your post-session feedback and reflection form. And we, on August 18th, we are going to be, the topic is invoking the Americans with Disabilities Act in abuse or neglect cases. So we recommend that participants sign up early, as soon as that echo response comes out, and that way you can get on. We also encourage our NM FAP practitioners to sign up to present a case or an issue at one of our upcoming problem-solving process sessions. The case or issue does not have to be on the same topic as the session, but can be any case or any issue relevant to our practice for which practitioners would like to get input from the group. Our sessions announcements contain links to sign up and case presentation forms. To submit a case or issue, please complete and send the form to our coordinator, Jen, at echonmfap@gmail.com. So I want to thank everyone for participating, and especially you, Dr. Davis, for taking the time to sit and chat with us and give us some really important information. And everyone is kind of thanking you and appreciative in the chat as well.
Yes.
Thank you.
Yes. Thank you so much.
Absolutely. Thank
Great.
you.
Yeah, it's great to see you all.
Dr. Davis, do you have contact information? So if we have anybody that would like to pick your brain or ask a question, would you be available to them for that?
Yeah, I'll just give them an email. I mean, I've got a university email, but it's kind of a decoy. I don't check it very often. And so I'll give you the real email address. Should I just give it now, or should I?
Sure, give it now, and then we can, Leslie,
Okay.
do you want to take it down too, so we can put it in when we put in the folder?
Sure.
G Davis, GDAVIS 43, which was probably my age the year I got that, but gdavis43@comcast.net.
Thank you so much for that. All right, y'all, it's Tuesday. Everyone have a good rest of your day and take care of yourselves.
Bye. Thank you.
Thank you.